I'm very honoured to speak on behalf of a lot of collaborators on the evidence for single dose from several clinical studies and trials. And I'm from the Manta Intervention Trials Unit in Tanzania and the London School of Hygiene and Tropical Medicine. These are my disclosures. Well, I think we've all heard that there are significant challenges to achieving the WHO elimination vaccination target. And we have the accumulating evidence that a single dose could protect against HPV. And this would have significant benefits in terms of delivery, reduction in cost and reduction in doses. Is there a biological plausibility for a single dose of HPV vaccine? Well, the answer is yes. These vaccines are made from virus-like particles, the outer coat of the virus, essentially, and they generate antibodies, which are the main method of protection for the vaccines. But we are extremely fortunate that the size of the VLP, the virus-like particle, is extremely immunogenic. It has a size and structure that allows it to stimulate the immune system in a way that it almost behaves like a live, once only live vaccine. And you get very efficient generations of long-lived antigen-specific antibody producing cells. And these result in very long-term immune responses over 10 years with very stable antibody levels. We don't know our minimum antibody level for protection, but we know that the vaccines probably generate far more than we actually would need to protect. And their low levels of antibodies have been seen to be protective in animal models. So from biological plausibility, the case is good. Our initial data for single-dose HPV vaccine efficacy and immune responses came from 2 clinical trials where participants failed to get the full course of 2 or 3 doses. The first of these was the Costa Rica vaccine trial, which was a double-blind randomized trial of 3 doses of Cervarix in Costa Rica. All participants got the hepatitis A vaccine. For various reasons in this study, and related really to the conduct of the study, women missed visits and received only 1 or 2 doses. For example, they might have had to go and have a medical appointment or they were pregnant. They followed the 1-dose arm alongside the 2 and 3 dose arm, and they had a control arm. And what they saw here was that there was really no difference in vaccine efficacy for prevalent HPV 16 and 18 infection. Those are the types that cause 70% of cervical cancers. And just in blue at the bottom is a snapshot. There are many publications from this study, but a snapshot to show you that vaccine efficacy for prevalent HPV was about 80%, 83% in all arms. And the 1-dose arm had equivalent vaccine efficacy to the 2 and 3 dose arms. So very encouraging data. And these particular data come from 11 years after those participants got a single dose of the vaccine. The second trial was the India IARC implemented study, a very large trial in India, nearly 18,000 women and girls aged 10 to 18 years that were being randomized to 2 or 3 doses of Gardasil. At that time, for reasons unrelated to this study, India suspended all its HPV vaccination research trials. And this led to some girls accidentally getting only 1 dose. And again, these girls were followed, and they also enrolled an age-matched unvaccinated control group for comparison here. Now, we have data up to about 9 years in this cohort, and again, they're being followed long-term. And very similar to Costa Rica, again, you can see this in blue at the bottom. We have excellent vaccine efficacy here against new cases of HPV 16 and 18. And also against persistent HPV 16 and 18. That is, the infection is detected at more than 1 consecutive visit. And these are very high efficacy rates here, well over 90%, and the same really in the 1-dose arm compared to 2 and 3 doses. Now, these trials are not randomized. These were observational cohorts set up as a result of incidental factors that related to those studies having a 1-dose arm. They had one other important immunogenicity result I would like to show you, and that is the stability of the 1-dose antibodies. What we can see here on this graph is that there is 11 years of...
I think I see a comment that some participants are asking if you could just speak a little bit more slowly.
Of course, sorry, yes, I will. So on this graph, we have 11 years of follow-up on the bottom axis, the x-axis, and we have antibody levels on the y-axis. And what we have is stable antibodies going right out in the grey line to 11 years with a single dose. There's no evidence that the antibody level is declining. It is lower than the 3-dose arm, but remember that I have shown you that efficacy is the same with 3 and 2 and 1 doses in this study, and very similar results were seen from India. So the single dose is generating stable antibody results going out for many years that are much higher than those seen with natural infection. No evidence of a decline. There are 2 randomized trial data now. One of them is the Kenshi trial, which will be presented after me. The other is the DoRIS trial, an immunogenicity and immunobridging trial in younger girls. And then we have a number of studies continuing globally. I'm trying to advance my slides. Okay. So the DoRIS trial is a first randomized trial in the current target age group for vaccination. It's 930 HIV negative girls aged 9 to 14 years in Mwanza in Tanzania, randomized to 1, 2, or 3 doses of 2 different HPV vaccines. Here we're using Cervarix, the bivalent, and Gardasil 9, the 9-valent vaccine. The girls are being followed up to month 60 and now likely to be followed up for a further 4 years. We have 155 girls in each group. We're looking here at whether the immune responses, seroconversion with antibodies after 1 dose is similar to 2 or 3 dose, and we do that by non-inferiority. We're measuring that at month 24. And then we look at whether the immune responses we generate in DoRIS are the same or not inferior to those that we saw in the 2 earlier studies from India and Costa Rica, and that's an immunobridging analysis. Now, I just want to show you this because you'll see these graphs a couple of times, just explain them quickly. When we do non-inferiority for immune responses, we have to set various statistical margins. In this case, I'm using the example of seroconversion. We want to make sure that the reduced dose regimen does not decrease seroconversion, that is the number of people who are positive at that visit for antibodies, by more than 5%. And this graphic just shows you how we measure this simply. The dotted line is our non-inferiority minus 5% or 5% margin. We want the proportion of girls who are seropositive and the 95% confidence limit to be the right of that line. If anything touches the line, we do not meet non-inferiority, and you'll see this graph shown a few times. And this is a standard margin used in many HPV vaccine trials. So here are the results for seropositivity at month 36, 3 years after the girls got the dose. We have a 1-dose, 2-dose, and 3-dose group, and 2 different vaccines. The first thing to notice on this slide is that seropositivity is very high in all the girls 3 years after the 1 dose. Here we are in this group, this column here, and very, very high in the 2 and 3 doses. More than 99% of HPV seropositives and more than 98% were HPV-18 seropositives. If we look at the red dotted line, we can see that HPV-16 antibodies shown in red here and here, HPV antibodies for HPV-16 1 dose are non-inferior compared to 2 and 3 doses for HPV-16 for both vaccines. And for HPV-18, non-inferiority was met for 2 doses versus 3 doses and met for some of the 1-dose comparisons. It just touched the line for a couple of the comparisons. So we have very high seropositivity 3 years after the first dose. Now looking at the antibody concentrations at month 36, we can see here, if we look at the dots, they show you the antibody concentrations for HPV-16 shown in red and HPV-18 in blue. Cervarix is on the left, Gardasil 9 comparisons are on the right. And we can see with 1 dose that we have HPV-16 antibody responses slightly higher than HPV-18. And these rise for Cervarix with each dose given. HPV-16 is always slightly higher. That has been seen in many, many studies. For Gardasil 9, again, after one dose, giving a second dose, you get a rise in antibodies. And then the third dose doesn't really increase the antibodies much more. So this is what we wanted to see. This is what other studies have previously shown. So our cohort is behaving immunologically as we would want. What's really important now is the plateau. So I showed you the Costa Rica plateau, that one dose gives you an antibody plateau that's stable going out after the vaccine for some years. The vaccine always peaks 1 month after the first dose. The blue line shows the single dose arm. And as you can see moving over to the right in each of these graphs for Cervarix, HPV-16 on top, and Gardasil 9's HPV-16 on top, and then HPV-18 below for both vaccines. We have a very good plateau in this young age group going out now to 3 years. For HPV-16 and 18 for the 2 and 3 dose, we obviously have higher antibodies, but then they decline and they continue to decline slowly. And we're even seeing a slight decline out to month 24. What about the strength of the antibody binding to its antigen? Is that affected by dose? Well, our data show that it isn't. We have a very good, strong antibody binding response. This is the antibody sticking to the antigen. This is done in a laboratory in America. And what we see here is that it's very similar for both vaccines and for whichever dose they're given. It's not affected by having one dose. It's the higher for HPV-16 than 18, but again, HPV-18 is also similar by dose, and this is the lines here, the black lines are the median antibody avidity indexes. So this is also very, very encouraging. Now moving on to immunobridging. So it's very difficult for us to measure efficacy against HPV in young girls because they're not sexually active when they're vaccinated, or most of them are not. And we would need to wait a long time for the HPV infection endpoints. So WHO has recommended that we bridge the immune responses in the younger girls to the populations where the efficacy has been shown. In this case, we're looking at the immune responses in the Costa Rica trial and the India trial and the Kenshi Kenya trial. And if these responses are similar and not inferior, then this is used to infer efficacy protection in the younger age group. This was done in one laboratory. We took samples for antibody testing from the three studies and from DoRIS. And we did this in the same laboratory in the United States. And that means that we can avoid batch differences. Okay. And our primary analysis excludes girls who are already infected with HPV. Similar non-inferiority graph now. We want everything to be to the right of that red dotted line. We're using a margin here of 0.5. So the antibody titer after one dose in DoRIS is not decreased by more than 50%. These were the comparisons. So one dose of DoRIS with Cervarix and one dose of the CVT with Cervarix are compared together. And then a second comparison is one dose of DoRIS Gardasil 9 and one dose of India Gardasil. Obviously, the vaccine is slightly different, but it's the closest comparison we have, and both have HPV-16 and 18 antigens. So here is the DoRIS immunobridging graph, and we start with Cervarix here. And as you can see, we're looking at HPV-16 antibody levels in red on the left. DoRIS is on the left and CVT is on the right of that. And then we have the HPV-18 antibody levels for DoRIS on the left again in blue and CVT on the right. And you can see that they are very, very similar. DoRIS is slightly higher in terms of its median antibody level. And this is exactly what we wanted to see. We did not want to see that the DoRIS in the young girls, the antibody levels were lower than in the Costa Rica trial. Similarly, for Gardasil 9, Gardasil immunobridging, we have the median antibody levels there in the black lines. They're higher in DoRIS than they are in India for these vaccine comparisons. And similarly for HPV-16 and 18, they look similar. Slightly lower for HPV-18, but DoRIS still has a higher median. So does this meet non-inferiority? And the answer is yes. So as you can see, the point estimate, the dot, and the lines are well to the right of our non-inferiority margin. So DoRIS one dose is non-inferior to the one-dose immunogenicity levels in the historical cohorts, CBT and India, at month 24. And this applies for HPV-16 antibody levels and for HPV-18 antibody levels for both vaccines. So this is a clear, we've met our targets clearly for the immunobridging objectives here. Now, we immunobridged to the Kenshi trial, and I really don't want to go through their results in detail because they're going to present those. So I'll leave the description of that trial to the Kenshi team, except to say that this is the first comparison of immunobridging where we have 2 African studies. And again, we have very similar results. We met our immunobridging target to DoRIS and Kenshi, in that the DoRIS girls, the younger girls than were in the Kenshi trial, have equivalent antibody responses to those in the Kenshi trial. This is a very important finding for the single dose evidence. And they will describe the Kenshi trial in detail, so then you will understand why this is so important. And this applied for both Cervarix and Gardasil 9, because Kenshi used Gardasil 9, and for both HPV-16 antibodies and HPV-18 antibodies. Here. And again, you can see everything is well to the right of our non-inferiority margin here and here for both HPV-16 and HPV-18. So in conclusion, we have very high seropositivity for antibodies for all doses of the 3 vaccines that we have looked at for HPV-16 and 18. Several studies in older girls and women have now demonstrated efficacy for HPV-16 and 18 endpoints with a one-dose regimen. One-dose antibody levels by dose and vaccine and the trajectory of the levels over time is consistent across the studies, and these are stable really from month 12. And this includes the responses in the target age group of 9 to 14-year-old girls. For avidity, the binding of the antibodies, there's no difference between 1, 2, and 3 doses for the vaccines. We've met the immunobridging objectives that are required when you're looking at a group where it's difficult to measure efficacy, and this supports single-dose use in this age group. We do have some gaps. We need further information on the dose reduction for HIV-infected girls and obviously for older females. And just an update that the UK met to review the evidence from all these studies and basically came up in August with an issuing of advice to move to a single-dose vaccine regimen. This will be pending a final policy decision, but it does include a consideration of a one-dose schedule for the routine adolescent programme. And similarly, the strategic advisory group of experts on immunization at WHO have also reviewed the evidence to date and made a recommendation for 1 or 2 dose schedules for the primary target of 9 to 14-year-olds and also for 15 to 21-year-olds, with a recommendation that HIV positive and immunocompromised should continue with 3 doses if possible. And again, this needs to is pending formal WHO endorsement and inclusion in the HPV position paper. I'd like to thank many investigators here and acknowledge all our partners and the HPV single-dose vaccine evaluation consortium and our funders, the MRC Joint Global Health Trials and the Bill and Melinda Gates Foundation. Thank you very much.